All right, so today we're going to speak about revision total hip arthroplasty. I'm Matthew Heppenstall. I'd like to acknowledge Joshua Rizal, who contributed several slides to this talk. These are my disclosures, and it should be noted that I do have several industry relationships, but none of them have direct bearing on the topic today. The reasons for revision total hip arthroplasty in 2020, the top three are instability, infection, and aseptic loosening, but it's important that we also think about the other ones, including periprosthetic fracture, polyethylene wear and osteolysis, and of course metallosis, psoas tendonitis, leg length discrepancy, and other less common diagnoses. Evaluation of the painful total hip is the beginning of any revision surgery. So when presented with a patient who has hip area pain, we're going to start with a history and physical examination, and that's going to dictate the necessary imaging and labs. On history, we really want to focus on the onset of symptoms. Was there trauma? Was there a pain-free interval after the first surgery? The triggers, is there startup pain, suggesting perhaps a loose component, or rest pain, suggesting the possibility of infection or tumor? What's the location of the pain? Is it in the thigh, suggesting a problem with the femoral implant? Is it in the groin, which is more commonly associated with an acetabular complication? Or maybe it's buttock pain, which can come from the acetabulum depending on exactly what's going on, but can also come from the abductors or even be referred from the spine and unrelated to the hip. Are there associated symptoms such as a limp that would suggest a mechanical problem, or systemic symptoms that might suggest infection, or even neurologic complaints that might steer you to look at the spine again? Physical examination, we're going to examine the patient for gait and station. What are the limb lengths? You need a good lumbar exam to rule out referred pain. Evaluate the hip in terms of range of motion, strength, tenderness, incisions, swelling. And a neurovascular examination, both to understand the status of the extremity you may be operating on, and also to look for signs of neurologic or vascular causes of lower extremity pain. On your imaging, you're going to start with plain radiographs, and these are really the workhorse for evaluation of a painful total hip. Oftentimes your diagnosis will be staring right at you, whether it's a loose component, a malpositioned component that's causing dislocation or irritating the psoas tendon. But sometimes the etiology is not evident, or sometimes we need additional information. CT scan can allow us to better quantify the volume of bone that's affected by osteolysis. It helps us understand the three-dimensional relationship between the implant and bone, and particularly recognize problems with femoral, but also acetabular anteversion. It can be used to better establish the size of bone defects and the integrity of the anterior and posterior columns, to rule out a pelvic discontinuity, although certainly various oblique pelvic views can help us with that assessment as well. MRI, whether it be a MARS, a metal artifact reduction sequence MRI, or a Maverick MRI, can help us look for soft tissue problems around the hip, such as abductor deficiency. Also can help us identify osteolysis and synovitis and evidence of particle debris and pseudotumors. Nuclear medicine tests used to be an important part of our diagnostic workup, less so these days because the sensitivity and specificity are not high. Nonetheless, let me rephrase that. The specificity is not particularly high. The sensitivity of nuclear medicine scans for abnormalities is reasonable, however, and so if you have a patient who has severe hip area pain and they're convinced it's coming from the device, and you think maybe it's not, then sometimes a negative nuclear scan can help reassure the patient and their other providers that the hip isn't the source of the problem after x-rays and labs have been negative. Laboratory testing obviously is an important part of evaluation for infection, which will be discussed in another talk, but also is important for evaluation for metal ion levels with variety of failure modes. So osteolysis and particle disease are the classic problems that we run into, limiting the durability of total hip arthroplasty. Now, these are less of a problem now than they were in the past due to improvements in polyethylene, but they're still very important. So this is really a foreign body granulomatous reaction. Historically, we were unclear as to what the source was. At first, we really focused on cement, and it was called cement disease. But then with the introduction of modular cementless implants, the incidence actually went up, which took the attention off of cement and onto polyethylene, and that was due to both articular and backside wear. However, with improvements in polyethylene, we still see it, and we really realize at this point that any particle can be responsible, and that it really is just a foreign body reaction. The magnitude of that reaction depends on the dose of a foreign body, that particular material. Is it cement? Is it polyethylene? Is it metal? And the particle size. The smaller particles are actually more pathologic. The ones that can be phagocytosed, that are smaller than 10 micrometers, are much more likely to elicit osteolysis and synovitis. And there are host factors. There are patients who seem to be responders and non-responders. And there's really an alphabet soup of intracellular and paracrine mediators that play a role. Several of the interleukins do, as well as TNF and the toll-like receptor and rank ligand. And this is science that continues to evolve day by day and week by week. So the diagnosis of osteolysis and particle disease, the history and physical are of course important, but the diagnosis usually comes from imaging. You're going to start with radiographs, and they may show you eccentricity of the femoral head within the acetabular component related to polyethylene wear. You can also see the classic radiolucent lesions within the bone, and these are expansile or permeative lesions. They may be cystic in appearance. This is very different from the radiolucent lines that you see with a loose component, or from the just generalized washed out osteopenic appearance that you see with stress shielding. A CT scan or an MRI will better show you the magnitude of bone that's affected, and often this three-dimensional cross-sectional imaging will show that the defect in the bone is far larger than you can appreciate on X-ray. Labs are very important. Infection can be a cause of bone lysis, and you also want to evaluate for metal ion issues. Not just metal-on-metal hips, but even patients who have trunnion issues can develop osteolysis related to the trunnionitis rather than polywear, and so it's important that you evaluate those parameters before going into the operating room. So when it comes to treatment, you have several options available to you. You can observe the patient, and this is typically going to be your asymptomatic patient who doesn't yet have severe bone loss. If you have progressive bone loss or you have symptoms, obviously those things are going to drive you to some form of revision surgery, and then you're really deciding, are you going to just revise the bearing, or are you going to revise the components? Any components that are malpositioned or loose from the bone, obviously those are going to revise, but if you've got well-fixed and well-aligned components, you still have several things to consider before deciding you're going to retain an acetabular shell. So you want to look at the component manufacture and the shell size. You want to know, is it modular versus a monoblock component? Are there screws or screw holes? What's the shape of this of the shell? Is it a hemisphere versus elliptical? What's the shell thickness? What locking mechanism is present? What's the track record? And what's the potential of the shell to accept constrained liners? All these things are going to influence what it would take for us to remove the shell. They're going to influence what new kinds of liners we may be able to place. Are they highly cross-linked polyethylene? Do they have a good track record? Do we have availability of large diameter bearings for stability? Do we have lip liners if necessary? Do we have dual mobility? Do we have constrained liners? Is it a big enough shell that we can cement somebody else's liner into place? And these things are all very important, particularly considerations relative to hip stability, because historically the outcomes of isolated liner exchange have been generally good if it doesn't dislocate, but there's a relatively high rate of dislocation, somewhere between 6 and 25%, depending on the study you look at. And 25% is a very high number for failure, and so you really want to be avoiding doing poly exchanges that force you to put in a small diameter bearing like a 22 or a 28, where you may be running into dislocation issues. So pseudotumor metallosis and trunnionitis is a very timely topic. People are spending a lot of time talking about this, and there are a lot of test questions about them. It's important that you understand what we're talking about here. So with metal-on-metal evaluation, these patients can develop what's called an adverse local tissue reaction, or ALTR. And although this was first described after the large head metal-on-metal failures, the same kinds of failures have been described with dual modular femoral stems and frankly just from trunniinosis and taper corrosion. With all these forms of metal failure, the particles that are released, the metallic particles, are very small, but they're far more numerous than the polyparticles that are released from the articulation in metal or ceramic on polyethylene total hip arthroplasty. So we've all heard about pseudotumors. What is a pseudotumor? Well, it's a diffuse lymphocytic infiltrate. It's been called ALVAL for aseptic lymphocyte dominant vasculitis associated lesion. It is, again, a biologic response to metal wear. It is not a tumor, and there is no increased cancer risk. There are a variety of sources of metallosis, and you need to understand them. Basically, you've got your metal-on-metal articulation failures, and then you've got your trunnion or taper corrosion problems. So the metal-on-metal articulation failures, these initially, again, were hip resurfacings, although the same problem has been seen in both large and small diameter metal-on-metal total hip arthroplasty. And indeed, we've had a bigger problem with metal-on-metal total hip arthroplasty than with hip resurfacing, and probably that's because of a combination of metal-on-metal articulation failures and trunnion problems in the same patient. We also see some metal-on-metal problems with catastrophic poly wear, resulting in the metal head rubbing against the acetabular shell. But all these articular failures are essentially mechanical abrasive wear, resulting from edge loading or the loss of the polyethylene. These tend to have a 1-to-1 cobalt-chromium ratio when we check metal ion levels, and really the diagnostic metal ion thresholds for these metal-on-metal articulations are relatively high. You're typically going to have over 5 parts per billion, and diagnosis is usually confirmed with over 7 parts per billion. In most cases, you're going to have more than 10 parts per billion in these failures. Alternatively, when you run into trunnion issues, these trunnion issues have probably been hiding in plain sight. They've been present in metal-on-poly hips all along. They certainly contributed a lot to the metal-on-metal total hip debacle. They were a big part of the modular femoral stem debacle with the neck modularity. And the issue there is mechanically assisted tribocorrosion or crevice corrosion. With corrosion, you end up releasing a different ratio of metal. So you have about a 2-to-1 ratio or higher of cobalt greater than chromium. And interestingly, the metal ion levels are often quite marginally elevated, with a cobalt maybe just between 1 and 2 parts per billion is often enough with these trunnion issues to create a biologic response. So why are we running into issues with our trunnions now? Well, it may always have been there. It may have been masked by polywear and osteolysis in the past, but our heads are getting bigger, and our trunnions are getting smaller, and so that means more torque on a less rigid trunnion, which can mean more motion and more corrosion. Also, our modern trunnions have been more optimized for ceramic, and what's best for ceramic is not necessarily best for metal, and there have been several tests showing that some trunnions perform very well with metal bearings and others very well with ceramic bearings. It's important to acknowledge that all modular junctions in total hip arthroplasty carry risk. You see there have been the head-neck modularity runs into trunnion issues, but neck stem issues are real, and you have failures there. Stem sleeve modularity can result in fractures, and mid-stem modularity can result in fractures. So we've really had some level of problems with modularity at every level. The diagnosis of metal problems, again, goes from your history to your physical examination to your plain radiographs in your labs. On history, it's important that these patients often have more nebulous complaints. They're often buttock as opposed to your typical groin or thigh complaints, and so you don't want to just blow off these patients with buttock complaints. You really want to work them up. Physical examination can be less specific if there isn't a mechanical failure, but there's just generalized pain. Your plain radiographs, you can look for things like vertically oriented acetabular components, which will explain a higher rate of metal-on-metal wear. Obviously, you want to rule out any component malposition or loosening. And labs to evaluate for infection as well as the metal ion levels we've already discussed. So again, just to reinforce this, always check an ESR and CRP. If they're elevated, you need to aspirate that hip. And it's important to obtain a manual cell count in cases of potential metal failure. Metal ions can be, metal particles can actually be mistaken for white blood cells when a automated count is performed. And the metal ion levels, should be less than 1 or 2 parts per billion in a metal on poly or a ceramic on poly hip, and less than 7 parts per billion in a metal on metal hip. The high ratios suggest taper corrosion, and the equal ratios suggest articular wear. An MRI is an important part of your evaluation of these metal issues. This is going to be a MARS MRI or a MAVRIC MRI. MARS stands for Metal Artifact Reduction Sequence, whereas MAVRIC is the newer version, and this is what's called a multi-acquisition variable resonance image combination. Regardless, these images will help you identify pseudotumors and fluid collections, which are perhaps the most common finding with metal-on-metal problems is the fluid collections. You can measure synovial thickness and abductor integrity. It can also be assessed on these scans. The treatment for these metal-on-metal hips and trunnion issues is going to... So if you have a symptomatic metal-on-metal hip with abnormal ion levels or an abnormal MRI, or if you have a painful total hip and you discover trunnienosis based on ion levels and or your MRI, these are hips that are going to have to undergo revision. At revision surgery, you start with soft tissue debridement, removing all the metal-stained tissue to the extent that that's possible. Obviously, you don't want to cut out the abductor, but do everything you can. You're going to revise any loose or mal-positioned implants, but you have to remove your source of cobalt chromium. And so even if your femur and your acetabulum are well fixed, if you've got a metal-on-metal bearing, typically you'll be removing both sides of that bearing couple. In the case where you had a large diameter metal-on-metal bearing with a resurfacing style acetabular shell, there are case series reporting good outcomes by just revising the femoral side and using a dual mobility construct and putting the new large polyethylene articular bearing against the retained monoblock shell. The decision to do that is going to be, first off, you have to acknowledge to yourself and to your patient that it's off-label. And then second, you have to think about what is the coverage angle of that particular component. What is the component position? But the reports actually show similar and in some cases superior outcomes with that reconstruction compared to removing a well-fixed shell on the acetabular side, so that's a consideration. If you have a dual modular stem, that's going to have to come out. These cases sometimes require extended trochanteric osteotomies for stem removal. If the problem is just trunnion corrosion, taper corrosion, usually you can keep the trunnion and retain the femoral component unless the trunnion has been damaged. Obviously, in the case shown here with gross trunnion failure, this femoral component has to come out. But if you just have corrosion, you can do your best to remove the corrosion products, with a lap sponge, or there's been descriptions of using other tools to help remove corrosion products to the extent that it's possible. But then just place a titanium sleeve over the taper, so you've got a new fresh taper and a ceramic head. And you can actually retain that femoral component. You've removed the cobalt chromium from the equation, which is really the issue, and the titanium sleeve on the titanium stem, you don't have ongoing corrosion, at least at a few-year follow-up. The reported outcomes have been quite good. With all these metal-on-metal failures or trunnion failures, you have to be worried about the status of the abductor, and so you should be prepared to perform an abductor reconstruction if necessary. Mechanical loosening and failure of osseointegration are amongst the most common causes of revision after total hip arthroplasty. It's important that you learn to recognize a loose stem. When we look at a cemented stem, we can classify that stem as definitely loose, possibly loose, or not loose. For definite loosening, we're looking for really objective criteria. There's a stem fracture. There's a radiolucent line between the stem and the cement. There is subsidence of the stem based on comparison of serial x-rays, where you have a fracture through the cement mantle. Signs of possible loosening primarily are radiolucent lines between the cement and the bone. It's important to acknowledge that radiolucency between the cement and the bone can occur normally. It's possible the cement never got all the way to the cortex. As the cortex expands with age, you'll evolve increasing lucency. The difference between these normal lucencies and the radiolucent lines that are concerning for loosening is the fact that the lucency is narrow and it's surrounded by reactive penciling. By that I mean a narrow zone of radiodensity, which indicates the bone is responding to the motion of the cement mantle inside the bone and forming a sort of corticated wall around the loose implant. With cementless stems, when they're loose, it's the same basic finding here. Obviously, we're not looking for fractures of a cement mantle that's not present. We're looking for circumferential or progressive radiolucent lines. Again, these are not just any radiolucency. Radiolucency can be osteopenia, it can be stress shielding, it can be osteolysis. We're looking for linear radiolucencies, radiolucent lines. And again, for that reactive penciling, that sign of new sclerotic margin around an implant that's moving within a space. You'll see evidence that the stem has subsided from prior x-rays in some cases. You'll certainly often see a supportive pedestal, which is bone forming at the tip of the stem to prevent it from subsiding further. And then you'll see the lack of signs of osseointegration, specifically the lack of spot welt. So what is stress shielding? Well, it's not osteolysis and it's not loosening. Stress shielding is proximal bone atrophy or resorption that occurs in the setting of a distal stress transfer. Now, this is classically a problem for cylindrical cobalt chromium fully coated stems, but really it can happen with any stem that achieves distal fixation, particularly if that stem is stiff, bulky, and non-tapered, resulting in a focal rather than gradual stress transfer. The stiffness of a solid stem is related to Young's modulus of elasticity, which of course relates to the material, but also to the radius to the fourth for a solid cylinder. If you think back to Wolff's law, in a healthy person, bone is going to adapt to the load under which it's placed. If you put more load on it, it gets stronger. If you take load away, it gets weaker. Bone maintenance requires continued remodeling of the bone, and this is mediated by mechanotransduction, and it requires cyclic loading. And so when you have this distal stress transfer, the unloaded proximal bone atrophies. Here's a case example. This is a 61-year-old male who had a proximal femur fracture, and his care was delayed by workers' compensation. He was having pain. Eventually, he had a lag screw removed. That didn't solve his pain. In fact, it allowed his non-union to displace, and he then fractured through this derotation screw. So we converted him to a primary total hip arthroplasty. We used a revision-style femoral stem to bypass the defect from the two screws distally. This is the largest diameter of the short version of this distal fixation stem. And you can see that even though it's the largest diameter, it barely filled this patient's capacious canal. And luckily, we thought we got away with it. It did not subside. But here he is at 2-year follow-up, and you can see how the proximal femur has appeared to disappear. So we have massive stress shielding. There's no osteolysis. There's no loosening. This guy doesn't have any polywear, and we don't have the linear radiolucencies with reactive penciling of a loose implant. We just have the bone just seems to have disappeared. We have a diffuse bone resorption above the distal stress transfer. Now, a lot of patients with stress shielding may present with thigh pain, but this patient actually did not. So this is a year later, and when we saw him at 2 years, we were a little worried something like this might happen, but he was asymptomatic and there was not much to do. Well, obviously at this point, there's something to do. So he's got a fracture just distal to the tip of the stem, but the stem itself is well fixed. The bone it's fixed to is pretty atrophic, but there's still bone around this implant. It's just markedly osteopenic. So in this setting, we treated it as a Vancouver C, although I guess you could call it a B1 fracture because it was right at the tip of the stem. Regardless, it's a well-fixed implant. So we went ahead with an open reduction internal fixation, and because of the massive proximal bone loss, we applied an allograft strut. And as you can see, a patient went on to fracture union with callus, and actually there was proximal bone restoration through some combination of incorporation of the allograft and the fracture callus itself. So this obviously brings us to the topic of periprosthetic fracture. In order to address periprosthetic fractures, you really need to understand the fracture classification. This is the Vancouver classification. You have your Vancouver A fractures, which are basically avulsions of the greater or lesser trochanter. The AL fractures affecting the lesser trochanter are exceedingly rare, and oftentimes what is misdiagnosed as an AL fracture is actually a B2 fracture, so a fracture affecting not just the lesser trochanter, but the medial calcar, resulting in a loose implant. So it's very important that you don't make a misdiagnosis there. Your B1 fractures are fractures around the implant without loosening. Your B2 fractures are around the implant and there is loosening present, and your B3 fractures are around the implant with loosening present and significant bone loss. And then you have your Vancouver C fractures, which are well distal to the implant with a well-fixed implant. So your algorithm for treatment of these periprosthetic fractures is dictated by your classification. The Vancouver A fractures are typically non-displaced and treated non-operatively. If they are significantly displaced and there's adequate bone stock, open reduction internal fixation can be contemplated. Your B1 fractures, the implant is going to be well fixed, so you can go ahead with an ORIF even though the fracture is around the implant. This is a controversial area, however, because oftentimes what's diagnosed as a B1 fracture is actually a B2 fracture. You have to be very vigilant to look for loosening. Obviously, if the stem is loose, you can fix the fracture and the stem will still be loose, so that the B2s and the B3s are going to revise the stem. Generally, you're going to reconstruct the femur around the stem after potting something distally. You're going to cable that bone around, and if in the B3s, if you've got significant bone loss, you may be adding an allograft strut for bone restoration. Generally, these are going to be reconstructed with your monoblock or modular fluted tapered stems, but in cases of severe proximal bone loss or comminution, you may be considering an APC, an allograft prosthetic composite, or even a megaprosthesis. And if in your Vancouver C fractures, you're going to be looking at an ORIF. These are essentially just femoral shaft or distal femoral fractures. There happens to be a hip replacement there, but the hip replacement has not been compromised. In these cases, the key is that you want to overlap your plate by the stem by at least 2 cortical diameters. You don't want to have a fracture between the plate and the stem. So as you see here, chronic femoral loosing is a risk factor, and although these happen to all be loose cemented stems at risk of fracture or with fractures present, cementless stems are a major risk factor for periprosthetic fracture. This is an 84-year-old female Holocaust survivor. She presents here with a Vancouver B2 fracture. It's a fracture around the implant. The implant is loose, but we do have an intact isthmus below the level of the fracture. So what are we going to do in a B2 fracture? We're going to go ahead and revise the stem, right? So, yep, it's a B2 fracture. We're going to revise with a distal fixation. We're going to cable the bone around the implant, but what can we learn? We really want to learn to avoid this. So this 84-year-old with a femoral neck fracture a year or two earlier, she probably should have been cemented. And so we're going to cement most of our hemis and cement more of our primaries, and this is how we're going to reduce our incidence of periprosthetic fracture. And periprosthetic fractures are the gift that keeps on giving. So 3 years later, she then presents with a Vancouver C fracture distal to her revision implant. Again, I guess this is probably a B1, not really a Vancouver C, since it does wrap around the implant, although the implant is well fixed. So this ends up getting treated with an open reduction internal fixation. And obviously we need to bypass that and go long on the plate. But we can't go too long because the patient's got a trochanteric plate. But this went on to heal okay. So there's a completely different classification for intraoperative fractures. This is, again, a Vancouver classification. It's just not the Vancouver classification that you hear as much about. So the intraoperative classification involves types and subtypes. Type A affects the proximal metaphysis. Type B is a diaphyseal fracture along the stem, whereas a type C fracture is distal to the stem. Your subtypes, a subtype 1 is a cortical perforation, subtype 2 is a non-displaced crack, and subtype 3 is a displaced or unstable fracture. So for your type A1 fractures, which are proximal metaphyseal perforations, you can really just ignore them. This is, often can be an anterior approach issue if you didn't have the proper starting point, but as long as you redirect and bypass these with the primary stem, you don't really need to do anything because there's not really a fracture. Your A2, these are the most common, the proximal metaphyseal little calcar splits, non-displaced crack. This really just needs one cable proximal to the lesser trochanter. If there's not enough bone there, you can certainly place a cable distal to the lesser trochanter, and there are those who will place one above and one below, but studies show that that's not necessary if it's truly a non-displaced crack. Your A3s are displaced or unstable proximal fractures, and these are going to require multiple cables to stabilize the fracture itself, and then you want a stem that's going to adequately bypass the fracture. You need to make sure you're getting axial and rotational stability distal to the fracture, and that may be achieved with the primary stem, but oftentimes this might require a bulkier or longer primary stem, and a revision style stem is going to be necessary in some cases. Your B1 or B2 fractures, these are diaphyseal fractures, but it's going to be a cortical perforation or a non-displaced crack in the cortex. This is often at the tip of the stem, and so you're either going to have to remove the stem and replace it, bypass them with a longer stem, or if your stem has solid fixation proximal to the crack or the perforation, you could elect to bypass the defect with a plate or a strut and keep your shorter stem. B3 fractures are displaced and unstable, and so these ones you're going to have to bypass with at least your stem, and then cable around it, and you may need a plate or a strut to address them as well. And then you've got your C2 and C3 fractures, and these are either non-displaced or displaced unstable fractures, distal to the stem, and these ones are going to require internal fixation. You basically have to fix the fracture and then span your stem by at least 2 cortical diameters. So moving on from fracture to dislocation, recurrent dislocation is certainly one of the most common causes of revision in the modern era. Incidence is between 1% and 2% following primary total hip arthroplasty in most studies, although it can be substantially higher, 5 or 6% in some studies. It's been reported to be up to 27% following revision total hip arthroplasty, although these high numbers typically come from head and liner exchanges from the posterior approach. The combination of large heads, dual mobility, and improved revision stem offsets, etc., have improved this number, but it's still certainly much higher in revisions than in primaries. The majority of these fractures are going to happen in the first year, and many of those will be in the first 4 to 6 weeks postoperatively. If you have a late dislocation beyond the first year, you should consider things like infection, polyethylene wear, metallosis, abductor injury, or altered spinopelvic mobility as a possible explanation. So risk factors for dislocation include advanced age and female sex, osteonecrosis and hip fracture diagnosis, abductor deficiency, and of course cognitive or neuromuscular disease, as well as spinal disease. And certainly patients who have had prior hip or spine surgery are at higher dislocation risk. When you're evaluating a specific patient with a dislocation, again, you're going to start with a history, physical examination, imaging, labs, and a review of the operative report. On the history, you're going to be interested in the mechanism of dislocation and the direction. If the patient can't give you the specific direction and you don't have x-rays that will tell you whether it was a posterior or a anterior dislocation, you're going to want to ask where it was the leg stuck with the hip flexed, adducted, and internally rotated as you would expect in a posterior dislocation, or maybe it was stuck with the knee pointing out. They were stuck in external rotation and extension, suggesting an anterior dislocation. If at all possible, you do want to get the x-rays with the hip dislocated to confirm the direction. You're going to basically look at your imaging, you're going to look at on your physical examination, you're going to look for abductor power, leg length, range of motion, and any evidence of either excessive range of motion or impingement. You're going to look for spinal deformities, pelvic obliquity. On your imaging, you're looking at component positioning. Are your implants restoring leg length and offset? Is the inclination of the acetabular component proper? Is it anteverted adequately or too much? Is your femoral offset what it needs to be? Are any of your components loose? And when you look at radiographs, I really like this flexed seated lateral radiograph, and you can see here that the impingement in flexion is coming from the acetabular component being functionally retroverted in the seated position. And so that tells me what I need to fix at surgery in order to eliminate the impingement that resulted in this patient's dislocation. So fundamentally, you're looking for sources of impingement, such as the combined anteversion, the head-neck ratio, the presence of retained osteophytes or heterotopic ossification, or lack of appropriate offset. You're looking for issues with soft tissue tension, again, potentially related to leg length and offset, or possibly the capsular integrity. You're looking at your abductor function. Is it a structural problem? Do you have an abductor tear or possibly an escaped trochanter? Or maybe a neuromuscular problem. Was there denervation of the abductor muscles at the prior operation? Maybe the patient has spinal disease or another neurologic etiology. Finally, you're looking at your pelvic tilt and your spinopelvic mobility. Patients who are stuck standing, they're going to be at risk when they sit down of a posterior dislocation. Patients who are stuck sitting, they're going to be at risk of a anterior dislocation when they stand up. Those patients with the really stiff spines, they could potentially impinge anteriorly in flexion and posteriorly in extension. They may not have a safe zone. And so really understanding what you're up against can help you decide, do you need to reposition your components? Do you need to add constraint or dual mobility? Constraining the hip is going to be most helpful if the issue is a lack of soft tissue restraint, whereas if the issue is impingement, constraint is just going to make that worse. So you're better off changing your component position and potentially using dual mobility. So what are your treatment strategies? Well, you go from head and liner exchange up through component revision and even trochanteric advancement or abductor repair or reconstruction. So for head and liner exchange, obviously your parts have to be well fixed and acceptably positioned. Rarely, but sometimes it's enough to add a lip to the liner and maybe increase your head diameter or length. If you're thinking this is all that you need to do, just go back and think again. It certainly is the right option at times, but often you need to do a little bit more to solve dislocation. Very often these days we're considering dual mobility liners before constrained liners, but something that gives you additional stability to the hip is something that can be done. And even if there's not a dual mobility or constrained liner option for the socket that's in place, if the socket is big enough, you may be able to cement in a dual mobility or constrained liner into the retained shell. Component revision is going to be necessary if anything is not well fixed or is malpositioned. This is going to be necessary if you want to change your version, and sometimes it's necessary if you want to add length or offset, although sometimes that can be done through modular head exchange. When there's really nothing else to fix, trochanteric advancement can add tension to the abductors. And it's a technique that is not used as much now as it was in the past when we had fewer articular options, but this remains a very valid treatment option. And finally, if there's an abductor deficiency, repair or reconstruction can be a great option. So here's just an example of a patient who we were evaluating for an instability revision. She had a total hip done in an outside hospital. It was complicated by femoral subsidence. She ended up going back for head exchange because the leg was short after the femur subsided. And now she's a recurrent posterior dislocator. It should be noted that in the interim she's had a few different spine operations. Her initial dislocation was an extreme position, but her recent dislocations have been low energy and not extreme positions, and she notes that her hip gets stuck in a flexed, adducted, and internally rotated position, and that tells you it was probably a posterior dislocation. So her physical exam, no Trendelenburg gait, So we're not too worried about her abductor. The right leg is just a few millimeters shorter than the left. She does have diminished lumbar range of motion, and she has a lot more external rotation than internal rotation at the right hip, which is asymmetric to the other hip, where she has more balanced internal and external rotation. So we're thinking there may be a problem with the femoral version. And frankly, anytime you have a femoral component that subsides, typically these will subside and retrovert. And so we're thinking there may be a femoral version issue. Her hip flexor and abductor power was normal. The right foot did point outwards when standing. And of course, a laboratory workup to rule out infection is important and was done in this case. If you look at the radiographic workup, this patient clearly has a stiff spine. And in the standing position, the cup was nice and anteverted. But even in sitting, the patient had 31 degrees of acetabular anteversion. And so this is not the problem here is not inadequate anteversion of the socket, but the stem itself is only anteverted 4 degrees, as we were able to measure on a CAT scan. And the head-neck ratio isn't particularly favorable. If you think back, there was a skirted neck, and we got the op report and determined the patient already had a posterior elevated rib liner. So ultimately we decided there wasn't really anything we could do on the socket side. Adding constraint here when we see this impingement didn't seem like the right thing to do, so a femoral revision was our choice. So we revised the femur. In doing so, we were able to increase the femoral anteversion, improve the head-neck ratio, and leg length with elimination of the skirt. And the femoral osteotomy also triggers a robust scar response, and this patient has had no recurrence of her dislocation because we addressed the underlying etiology. So infection is a really important topic in revision total hip arthroplasty, but this is going to be covered in a separate talk, so we won't go into it here. Heterotopic ossification is still a problem after hip replacement in a select number of patients. So historically, it's important to know that this is more common with the Harding approach, but it can really happen with any approach. There's definitely an association with ankylosing spondylitis, also with head injury. Prophylaxis, historically radiation has been our prophylaxis of choice in high-risk patients, and the important answer for the test is that's 700 centigrade. There have been studies showing that that's more effective than 400 centigrade, and this can be either done in the 4 hours preoperatively or within 72 hours postoperatively. Another option is indomethacin, 75 milligrams for 6 weeks. 75 milligrams daily. It should be noted that there's several studies that show the use of aspirin for VT prophylaxis, in addition to the use of an NSAID as part of a multimodal pain regimen, can reduce your heterotopic ossification risk. Celebrex is probably just as good as indomethacin. And so, frankly, as we use more aspirin for DVT prophylaxis and more NSAIDs, we are seeing less heterotopic ossification, but this still happens. This person here has extensive Booker 3 near bridging heterotopic ossification, and this was with a modern approach and a modern prophylactic regimen with aspirin, and patient was unable to take NSAIDs, however, due to intolerance. So this can be resected if it restricts range of motion. It's important to wait until that heterotopic ossification is mature. At least that's a classic teaching, although we should acknowledge that in other parts of the body, they're considering going in sooner. So, the jury may be out on that. So acetabular reconstruction is a wide topic, and the challenges you face are going to relate a lot to the underlying diagnosis. So in conditions such as aseptic loosening, osteolysis, and infection, you can sometimes have pretty substantial bone loss. Whereas in other infections and in cases like instability or malposition causing psoas tendinitis, sometimes the bone stock is relatively preserved. When you think about the reconstructive challenge, you really have to quantify your bone loss, and the Peprosky classification helps us do that. Type 1 defects have an undistorted hemispherical acetabulum. Type 2 acetabular defects have a distorted acetabulum, but the columns are intact, and this really means that you're going to have some anterior superior bone and some posterior inferior bone that are of good quality, and you can wedge a hemispherical implant between those two spots and get some good initial purchase with or without some supportive augments or bone graft. And then finally, you've got your type 3 defects where you've got distorted and non-supportive columns, and you're really not going to get that A to P wedge from top to bottom, and these are the hardest cases. So the Peprosky classification requires identification of certain landmarks and bone loss in certain locations. You want to identify if there's any superior migration of the hip center, if there's any osteolysis affecting the teardrop or the ischium, and whether Kohler's line is intact or disrupted. The Peprosky classification goes from type 1 defects, as I said, through type 3, and there are subtypes. So within type 2, you've got supermedial, superlateral wear patterns, as well as a medial-only wear pattern. And with your type 3 defects, you've got the classic up and out, which is substantial bone loss greater than 2 centimeters with severe ischial and medial lysis, and the hip center is going up and out. You've got a lot of your reconstruction is going to be supported by graft. And finally, your type 3Bs. These are the most complicated defects. The Kohler line is compromised, so you've got lack of medial bone support. And often greater than 60% of the component is supported by graft rather than host bone. And these are your up and in defects. So the treatment of your acetabular defect is going to be determined by the pattern of bone loss. So the simpler Peprosky 1 and 2A cases will have a supportive rim, no bone lysis or no migration, or with the 2As they may have a little supermedial or superlateral migration, or a little supermedial migration, but you've really got intact columns. And so going back to that first slide, we had a good anterior superior and posterior inferior bone, so cementless cup with screws is going to be fine, and that only requires about 50% bone contact. So we get on to the type 2Bs, we really have superlateral bone loss, so you really lose the dome. So these patients will often need also a graft or augment to provide some superior support. And again, with the 2Cs, often you'll need some medial bone graft. It's the type 3s where we really get into needing lots of extra tools in the operating room. If you have greater than 2 centimeters of proximal migration and you've got ischial bone loss and medial lysis, if Kohler's line is intact and it's really going up and out, then these cases are often going to require one or more superior augments, and you may have an anterior superior or posterior superior augment. Because of the superior deficiency, they're going to need inferior fixation to avoid the acetabular component ripping out and going out laterally again. Your 3B defects, these are the hardest ones. Kohler's line is disrupted. In these, you have to be very worried about a segmental deficiency, with or without a pelvic discontinuity. And obviously, if the superior pelvis is not attached to the posterior or the inferior pelvis, that's a whole other challenge. But you're going to need augments and inferior fixation. And if indeed you do have a pelvic discontinuity, you may need to either acutely ablate the posterior column or distract it. You may need a cup cage or a triflange to reconstruct these. So going back to those landmarks we talked about earlier, a complex case like this, you've got superior hip migration, you've got teardrop osteolysis, ischial osteolysis, and Kohler's line is violated, and so that makes this a 3B up and in kind of defect. So cases of pelvic discontinuity, it's important to recognize them and to classify them. You've got acute pelvic discontinuities, and that's the patient who was doing well and then felt a crack and can't walk, or was having pain and could walk and then felt a crack and really can't walk. Or your intraoperative discontinuities, the one you create. Those ones are going to be unstable. There's no fibrous tissue across the discontinuity, and so you need to achieve stability. You need to reconnect the superior and inferior portions of the pelvis, and that's usually going to be done by plating the posterior column. Alternatively, patients with a chronic discontinuity, often there's a fibrous tissue spanning the discontinuity, and so the pelvic distraction technique has been described, in which the cup that's implanted is several millimeters larger than the reamed concavity, and really it distracts the pelvis, and you've got that rebound compression because of ligament ataxis. But regardless of the technique that's used, you're going to need to get fixation both above and below. And often cup cage or triflange constructs are going to be more reliable for you because they get fixation on both sides of the discontinuity. So some defects don't perfectly line up. This is a patient who had a prior pelvic fracture before the hip replacement, and then obviously the hip failed. So if you look at the hip center, it doesn't look that elevated compared to the contralateral side until you realize how low the ischium is displaced on that side, and there was substantial bone loss here, and this required substantial augments superiorly to reconstruct, and so this is sort of a 3A kind of defect. Moving on to femoral reconstruction. At the time of femoral revision, your goals are to achieve typically cementless fixation, and you're going to get your rotational stability typically with splines on the implant, and your axial stability most commonly with a taper, although historically cylindrical, fully porous coated implants could also achieve successful early stability and osseointegration, but that required a 4 to 6 centimeters of scratch fit. And really, after getting fixation, then your next goals are, restoration of biomechanics, leg length offset, really in the service of hip stability. So when you look at the Peprosky classification for femoral bone loss, the type 1s are the simple ones. These have intact metaphyseal bone. Diaphyseal bone is intact, and there's no varus remodeling. So really, this is almost a primary situation. You can often use a metaphyseally fixed implant, sometimes a primary one, and really any revision stem will do in this setting. Your Peprosky 2 defects are the most common, where the metaphyseal bone is substantially damaged, but the diaphyseal bone is intact, and these are kind of dealer's choice. Historically, the extensively porous coated stems were the workhorse here. However, these stems are being used less and less, and so many people have moved to monoblock tapered stems, or even modular tapered stems, although that stem design certainly has more complexity and cost than is necessary to solve this particular problem. When we move on to the type 3A defects, these are the ones with severely deficient metaphyseal bone and some diaphyseal damage, but at greater than 4 centimeters of intact diaphysis at the isthmus and no deformity. So these are the more complicated ones that can still be treated with a cylindrical, extensively porous coated stem because they've got that 4 centimeters of diaphyseal isthmus for that scratch fit. But tapered conical stems are, again, being used more and more for these defects. And with your Peprosky type 3Bs, the metaphyseal bone, again, is absent, but now you've got less than 4 centimeters of isthmus. And these are the ones where the cylindrically porous coated don't do nearly as well. Their track record is poor, and so really you want a tapered conical stem here. And there may or may not be varus bone remodeling here, and those can sometimes require osteotomies to straighten out the femur and get your fixation distally. Finally, your Peprosky 4s, these ones have absent metaphyseal bone, but they also have severe diaphyseal ectasia. And these are hard ones because there's really no isthmus to get stability. Sometimes you can machine a little bit of an isthmus and get away with a tapered conical stem. However, there's a high rate of subsidence in this particular pattern of bone loss, and these patients will sometimes get either an APC, an allograft prosthetic composite, or impaction grafting, or a megaprosthesis such as a proximal femoral replacement cemented distally. Before you can reconstruct your femur, you're going to have to get out your parts. So how do we go ahead about removing well-fixed implants? Well, first we need exposure. You want to choose an extensile exposure, and for most surgeons that's going to be a posterior or an anterolateral approach, although there are plenty of anterior surgeons who will talk to you about how they can use a DAA for the hip joint and actually extend that proximally to get to the inner table of the pelvis, and they can go direct lateral to the femur through a second window. So the bottom line is you need to be able to expose the part of the bone you're working on to do a good job. You need to clearly define your fascial level, have a low threshold for an osteotomy, whether it's a traditional ETO and extended trochanteric osteotomy, or the Wagner osteotomy that's been popularized by anterolateral surgeons, or even just a trochanteric slide to improve your exposure. So there's a lot of talk about the indications and technique for an extended trochanteric osteotomy. This is a great way to help remove a well-fixed stem. It's also very helpful to make sure you've removed all the cement before reconstructing the femur, particularly in infection where you want to get out every last bit, but also if you want to keep the cement from obstructing your path to perform a reconstruction. Obviously, the ETO will aid your surgical exposure, and sometimes it's necessary to achieve acetabular exposure. It can help you manage proximal femoral deformities, such as varus remodeling, and allow you a straight shot to the distal part of the femoral canal. And usually it's going to be followed by the implantation of a modular fluted tapered stem, although if you do have 4 to 6 centimeters of isthmus, you can still go ahead and put in a straight cylindrical stem if that's a stem that works well in your hands. The technique here, we generally want to keep the soft tissue intact to keep that trochanteric bone viable. You want a relatively long osteotomy, at least 12 centimeters. Anything shorter is going to be actually less rotationally stable. That surface area helps with healing, and shorter osteotomy segments have a higher rate of non-union. That being said, you don't want to go so long that you compromise the isthmus. So, you want to be long enough to make for good fixation of the osteotomy. You want to be short enough to allow fixation of your stem. And of course, you want to be long enough to do the job. You want to get past the fixation or the cement when possible to facilitate rapid surgery. The last thing you want to do is do an extended trochanteric osteotomy and then spend another half an hour picking at the cement. When it comes to cement removal, there's lots of tools available to you. There's osteotomes, pituitary rongeurs, ultrasonic cement removal. All these things require patience. And while it's important to be patient while you do each of these things so you don't damage the bone, you don't want to spend too much time. And so you should have a low threshold for an extended trochanteric osteotomy. Most surgeons will set a time limit on their attempts to remove cement from above and then go ahead to an osteotomy if they've exceeded that time limit. It's important to remember that sometimes you don't have to chase all the cement. Cement and cement revision has a good track record. There are several indications out there. It can help minimize your morbidity in your elderly patient, but it can also minimize bone loss in young patients with cemented stems. This has been extensively reported by the European colleagues. You can minimize your time in the operating room with these cement and cement revisions, and you can you're going to need to have a intact mantle and an intact cement bone interface to make this work. The technique, after extracting the stem, you're going to need to implant a new stem that's smaller than your original. You're going to need to enlarge the cavity somewhat with a burr and inject your cement at low viscosity. There have been studies showing that if you enlarge the cavity with an ultrasonic cement removal device, that does actually compromise the quality of the cement mantle that you create. The right tool makes all the difference, and on the acetabular side, acetabular bone or component removal used to be challenging when we used these wooden-handled curved osteotomes. Sometimes there was relatively substantial bone loss. However, with the newer tools, these explant tools that basically have a curved osteotome that is confined in the proper plane by having the same radius as the cup you're removing and centering itself with the femoral head that goes into the polyethylene of the liner, you can really remove most hemispherical cups with minimal bone loss these days. Abductor reconstruction is an important part of revision hip surgery. You really want to be aware of the ball of trochanter. Nothing spoils a complex reconstruction like recurrent dislocation. So you want to have a low threshold to make sure you have all the tools in the OR that you're going to need to reconstruct the abductor. It's really important to examine your patients preoperatively, identify abductor weakness and Trendelenburg gait. You don't want to just rule that out, you don't want to just attribute their limp to pain or leg length discrepancy or implant loosening. You really want to consider if they seem weak on exam, they may have a weak abductor, and what am I going to do in the operating room? So there are lots of options for abductor reconstruction. You can use an Achilles allograft, with a calcaneal bone block, and that can be sewn through the residual abductor to help reinforce your repair. There are muscle transfers that have been described, including transfer of the vastus lateralis, which is a extensive dissection down the femur to mobilize the vastus lateralis proximally and attach it to the abductor, or more recently described the gluteal transfers described by Leo Whiteside, transferring the gluteus maximus to compensate for the medius minimus and even for the posterior soft tissues. Furthermore, there's been descriptions of using dermal allograft, acellular dermal allograft, to reinforce abductor repairs. There's lots of techniques, and whenever there's lots of techniques that have been described, that means that no technique is perfect. There's few large series for evidence, but most series that are published with one technique or another have shown moderate improvement in strength and gait, with larger improvements in pain. The bottom line is you need to be prepared. You have to have a high suspicion. You have to have the equipment necessary to repair the abductor if it's necessary. You have to leave time. You don't want to be rushing out of your revision to the next room and not spend the time that's necessary to address the abductor if that's the issue. For these less common things like the Whiteside gluteal transfer, most surgeons aren't doing this more than once a year, and so you want to watch surgical videos in advance and mentally rehearse so that when it comes time to actually do the operation, you can do it reliably. All right, well, that was a whole lot of material in a relatively significant amount of time. Hope you got something out of it, and feel free to contact me with questions. I'd be happy to help any of you one-on-one for specific concerns. Okay, take care and good luck.